Pain management is a very common concern. When you look at factors that keep people from considering surgery of any kind, and joint replacement surgery in particular, concerns about pain, the level of pain, how it'll be managed is one of the major hurdles that we have to overcome as we help patients. Orthopedic surgeries can be painful, but I think we have, at this stage of the game, a lot of good data that shows us a pretty clear pathway on how to manage these. So the first step is to provide patients with pain medicine before surgery. The data seems to be pretty significant that if you give patients a combination of pain medicine before surgery, you can block the creation and therefore the intensity of pain before it's even started. So typically with our elective hip and knee patients before surgery, they will receive Tylenol, which is a good pain medicine. It's theoretically a COX-3 inhibitor, so it works on your brain as a pure analgesic. Most patients, depending upon their health, will receive an anti-inflammatory, typically Celebrex, which blocks a specific kind of cyclooxygenase, which is all part of the formation of prostaglandins and thromboxanes, which lead to pain and inflammation. Generally, the patients will receive a long-acting opioid before surgery, an idea to fill the opioid or these mu pain receptors to try to begin pain relief even before it's created. Some will receive a Neurontin, which is a medicine to help with neuropathic pain. Most patients get a one-time dose before surgery. And then we do our anesthesia with our spinal anesthetic for the surgery, our local wound infiltrations, which contain various combinations of anti-inflammatory medicines and local anesthetics, as well as in our knee, our specific nerve blocks like the adductor canal nerve block. So we do a lot up front, and we do see a lot of patients now, or we see a significant amount of the patients having reasonably good pain control initially after surgery. After surgery, we have to balance the medications we use versus the side effects. So most patients require some form of narcotic pain medicine. Narcotic pain medicines come with side effects. They can cause confusion. Nausea and vomiting is probably one of the most common things that's seen in about 35% of patients in some of the studies. Some get constipation, some people get urinary retention. So the less narcotic we can have you on, the better. I think I mentioned in one of the other videos, with the local wound infiltrates, we've seen a dramatic decrease in the amount of opioids that our nurses were giving our patients the first 24 hours. So we want to have the patient on the lowest opioid dose possible. So a little bit of it is trial and error, but in general we have a pretty good idea based on patient's age, activity level, previous opioid use, where they should be, and we can start them on an opioid post-operatively. And generally we just have to make small adjustments, either up or down. And they're on that depending upon the surgery for a number of days to a number of weeks. In general, hip replacement patients need less narcotic pain control than knee replacement patients because the surgery gives them such dramatic pain relief. Knee replacement patients have more pain, their recovery requires more work, probably more painful work, so they tend to be on the narcotic pain medicine a little bit longer. We're typically still using some form of anti-inflammatory medicine after surgery, and we're also continuing to use Tylenol after surgery in an effort to just continue to try to bring that opioid dose down. I think most patients should be off their narcotic pain medicine by about 12 weeks. I like to see most of my hip patients off theirs by right around that 10-14 day visit if possible. Certainly there are factors that influence that. The patient's pain history, are they on narcotics before surgery, and if so, how much are all variables that make pain management a very individualized process.